Hello friends, welcome to Health WIZAC, Medical Concepts Simplified. In this video, we will learn about hyponatremia. Hyponatremia is a clinical condition in which the plasma sodium concentration falls below 135 millimoles per liter. Hyponatremia is a very commonly occurring electrolyte abnormality in clinical practice. Sodium is a very important electrolyte of the extracellular fluid, which is responsible for a lot of crucial functions like nerve conduction, muscle contraction, and proper maintenance of water and mineral balance. Normal value of sodium is between 135 to 145 millimoles per liter. Depending upon the plasma sodium concentration, hyponatremia or low sodium can be divided into three categories: mild, that is between 130 to 134 millimoles per liter, moderate between 125 to 129 millimoles per liter, and severe, that is below 120 millimoles per liter. Symptoms of hyponatremia. As patients of hyponatremia usually presents with abnormal GCS, the symptoms can easily be remembered with the mnemonic called low GCS, in which L stands for lethargy, O stands for orthostatic hypotension, W stands for limb weakness, G stands for giddiness, nausea and vomiting, C stands for coma, and S stands for seizure. Now let's understand the causes of hyponatremia. Causes of hyponatremia can easily be understood with the help of a flow chart, which is divided into 4 levels depending upon the diagnostic evaluation. Hyponatremia primarily occurs due to the abnormal regulation of circulating arginine vasopressin level in the blood and the free water intake. Both of these tends to change the serum osmolality level. Osmolality is the particle or solute concentration of a fluid, which is normally measured in milliosmoles per kg. Normal serum osmolality level is between 280 to 295 milliosmoles per kg. Depending upon the value of serum osmolality level, hyponatremia can be differentiated into 3 categories. 1. True hyponatremia, in which the serum osmolality level is below 280 milliosmoles per kg. Second, pseudo hyponatremia, in which the serum osmolality level is between 280 to 295 milliosmoles per kg. And third, the factitious hyponatremia, in which the serum osmolality level is more than 295 milliosmoles per kg. True hyponatremia requires further evaluation, whereas the pseudo hyponatremia is present in the clinical conditions like hyperlipidemia, patients on IVIG treatment, and hyperproteinemia, and it can easily be remembered with the help of mnemonic called LIP in the lipids. Factitious hyponatremia is found in the clinical conditions like hyperglycemia, patients on mannitol treatment, and patients receiving glycine, especially as an irrigation during the TORP surgeries. Once the true hyponatremia is confirmed, the second level of evaluation is to check the urine osmolality level. Normal urine osmolality level is approximately between 500 to 850 milliosmoles per kg. Low urine osmolality is generally found in clinical conditions like beer potomania. Normal or high urine osmolality level requires further evaluation. Once the urine osmolality level of patient is evaluated, the third level of evaluation is to check the volume status of the patient. Depending upon the volume status of the patient, hyponatremia can be differentiated into 3 categories called hypovolumic hyponatremia, euvolumic hyponatremia, and hypervolumic hyponatremia. After evaluating the volume status of the patient, the fourth and final level of evaluation is to check the urine sodium concentration of the patient. Normal urine sodium concentration is around 20 milliequivalents per liter. Urine sodium concentration helps us to differentiate the renal cause of hyponatremia from the extrarenal causes of hyponatremia. So let's see how. In a hypovolemic patient, urine sodium concentration of more than 20 is usually found in the clinical conditions like patients on diuretic treatments, mineralocorticoid deficiencies, salt losing deficiencies, ketonuria, osmotic diuresis, and cerebral salt wasting syndromes. Whereas if the urine sodium concentration is less than 20, then it is usually found in the clinical conditions like vomiting, diarrhea, third spacing, burns, pancreatitis, and trauma. In a euvolemic patient, urine sodium concentration of more than 20 is usually found in the clinical conditions like glucocorticoid deficiency, hypothyroidism, stress, drug-induced, and SIDH. SIADH, or the syndrome of inappropriate antidiuretic hormone, is usually found in the clinical conditions like malignancy, patients with pulmonary disorders like pneumonia, tuberculosis, asthma, patients with CNS disorders like meningitis, abscess, cerebrovascular accidents, subarachnoid hemorrhages, and drug-induced. Drug-induced SIADH is usually due to the drugs like SSRIs or the selective serotonin reuptake inhibitors, NSAIDs, tricyclic antidepressants, etc. SIADH is also found in patients with pain, stressful conditions, and the patients receiving general anesthesia during surgeries. Lastly, the hypervolemic hyponatremia. In patients with hypervolemic hyponatremia, if the urine sodium concentration level is more than 20, then it is usually present in the clinical conditions like acute renal failure or chronic renal failure. Whereas if the urine sodium concentration level is less than 20, then it is present in the clinical conditions like nephrotic syndrome, liver cirrhosis, and congestive cardiac failure. After understanding the causes of hyponatremia, let's see the investigations that can help us to diagnose hyponatremia. Since there are a lot of causes of hyponatremia, diagnostic evaluation should be customized as per the clinical presentation of the patient. Some of the investigation that may prove helpful in diagnosing hyponatremia are as follows. First, the serum osmolality level. Serum osmolality level is usually low in patients with true hyponatremia, and thus it is used to differentiate true hyponatremia from pseudo and factitious hyponatremia. Elevated BUN and creatinine may be suggestive of renal dysfunction. Elevated serum potassium level may be suggestive of adrenal insufficiency. Serum uric acid is usually found low in patients with SIADH, and it may be elevated in patients with dehydration or with volume depletion. Urine osmolality is usually low in patients with beer potomania. Increased urine sodium concentration reflects the causes associated with renal loss of sodium. Radiological investigations like CT scan may be helpful in diagnosing the carcinoma, which is one of the important causes of hyponatremia associated with SIADH. Apart from this, thyroid function test and serum cortisol level may be helpful in diagnosing hypothyroidism and primary hypoaldosteronism. Finally, let's see the treatment part of hyponatremia. Patients with hypovolemic hyponatremia should be treated with isotonic normal saline infusions. In patients with euvolemic hyponatremia, we should first treat the cause. A detailed drug history of the patient should be taken, and if any drug is causing hyponatremia, then it should either be stopped or should be modified. In patients with hypervolemic hyponatremia associated with congestive cardiac failure, treatment should be done with ACE inhibitors, diuretics like furosemide, and AVP antagonistic agents like vaptans. Patients with SIADH should be treated with diuretics like furosemide along with oral salt capsules. Apart from this, demiclocycline and AVP antagonistic agents like vaptans should also be used to treat SIADH. In clinical scenarios of hypokalemia, it should be corrected aggressively, as treating hypokalemia countercorrects the hyponatremia. In patients with beer potomania, treatment should be done with isotonic normal saline solutions along with normal diet. Patients with acute symptomatic hyponatremia should be treated with hypertonic 3% normal saline infusion. The rate of correction should not exceed more than 6 to 8 millimoles every 24 hours. If the correction is done too rapidly, then it may give rise to a clinical condition called as osmotic demyelination syndrome, which is usually presented with confusion, hallucinations, acute flaccid paralysis, seizure, and even coma. While correcting the patients with hyponatremia, sodium deficit should be calculated with the help of formula called 0.6 into body weight into target sodium concentration minus starting sodium concentration. While correcting the patients with hypertonic 3% normal saline infusion, serum sodium level should be checked every 2 to 4 hourly to avoid the acute rise in sodium level. If sodium is found acutely rising, then it should be controlled with the help of free water intake, dextrose 5% saline infusion, and AVP agonistic agents like desmopressin. Friends, this brings us to the end of this video. Hope you find this information valuable in your clinical practice. Please do like and share this video. And for more such informational videos on medical topics, please subscribe to YouTube channel Health WIZAC, Medical Concepts Simplified. Thank you.